Hello, my name is Veronique Siach. I am a registered nurse enrolled in the Masters of Nursing program at Athabasca University. Today will be my rebuttal against my opponent's view that harm reduction programs are not medically necessary healthcare service. I am debating the pro side of this debate. This is the second video of 3 parts of the debate. I will be posting my closing arguments in a few days. I would like to begin again with the definition of harm reduction. So the Canadian Mental Health Association defines it as an evidence-based, client-centered approach that seeks to reduce the health and social harms associated with addiction and substance use without necessarily requiring people who are using substances from abstaining or stopping. For this debate, we'll be focused mainly on the topic of drug-related harm reduction methods. Okay, so to begin, I would like to praise my opponent for a very good presentation with many great points. Here are the 3 claims of their debate. Harm reduction programs fail to protect the residents of Canada. Harm reduction programs are unable to adequately meet the needs of the individuals who use them due to operational accessibility issues creating barriers for certain populations. And harm reduction programs are unable to restore the physical and mental well-being of residents of Canada, which is a parameter set out in the Canada Health Act. I'll be breaking down the evidence set out in each of these claims and proving my rebuttal with some evidence against the opposition. So for claim 1, harm reduction programs fail to protect the residents of Canada. So this claim is explained by my opponent saying that the controlled substances and injections are unsafe, and substance use causes negative side effects and other complications such as substance abuse, addiction, overdose, and infectious diseases. So my rebuttal to the claim that controlled substances and injections are unsafe is that the use of controlled substances such as injecting is much safer to do in a supervised location rather than in public. This is true for sanitary purposes and for risk of overdoses as well as violence. While interviewing users of supervised injection sites, Joe Zaghi and their group found that supervised injection sites are a safe place for vulnerable drug users who need to escape the violence on the street from others trying to steal drugs or drug paraphernalia. My rebuttal to the claim that substance use causes negative side effects and other complications is that these side effects and complications can be helped and avoided by supervised injection clinics. It's been proven that supervised injection sites reduce health risks such as public injection, unsafe needles, homelessness, mental health illness, negative interactions with police, and HIV infection. Not only do the nurses who work in harm reduction programs ensure the safety of the clients while using drugs, but they also treat wounds, administer immunizations, test clients for sexually transmitted diseases, and offer referrals to other healthcare services. Claim 2 is that harm reduction programs are unable to adequately meet the needs of individuals who use them due to operational and accessibility issues, creating barriers for certain populations. The opposition claims that harm reduction programs directly contraindicate the Canada Health Act's reasonable access to healthcare service without financial or other barriers. My rebuttal to the claim that harm reduction programs contraindicate the Canada Health Act is that most services offered for harm reduction services are free or have minimal barriers to access. So harm reduction programs do align with the Canada Health Act's pillar of public administration, comprehensiveness, and accessibility. As harm reduction programs become more popular, there's a shift to seeing them as a continuum within the medical model, rather than thinking the goal is to reduce substance use itself, but to reduce the risk of substance use instead, with the aim overall being to reduce barriers from high to low for clients. Some examples of accessibility programs are drug alert programs that have been placed in Vancouver to disseminate important information about the circulating drug supply to enable people to use more safely. It has been seen to be effective in 2/3 of drug users who use supervised injection sites. When they become aware of an alert, they subsequently change their drug use behavior to be safer. In Vancouver, they also started distributing crack pipes kits for free in the community, helping people find safer materials to use and avoid the risk of violence to that person. Claim 3 is that harm reduction programs are unable to restore the physical and mental well-being of residents of Canada, as per the Canada Health Act. This claim explains that harm reduction programs are not about treating the individual, and naloxone is not a treatment for substance use. I do not believe that harm reduction programs do not treat the individual. My rebuttal is that the goal of harm reduction programs is not for treating the substance use, but to reduce drug-related harms such as infections and overdoses. Vancouver Coastal Health, that had been handing out the crack pipes, they are made of Pyrex glass with heat-resistant filters that have mouthpieces, push sticks, alcohol swabs, and information on how to seek detoxification. This helps avoid the problems with unsafe pipes that were used and broken, causing lacerations to the face and mouth. Plus, there's always information about detoxifications with these kits. Supervised injection clinics are not only effective in reducing the sharing behavior and violence, but it also serves as a safe place where drug users can relax and use their illicit drugs without being harassed by the police or people on the streets. This model of care treats the individual in a way that ensures they're getting the care they desire in the safest way possible. The last claim that I will refute is that naloxone is not a treatment for substance use. It is true that naloxone does not treat substance use, but that is not the intent. Naloxone is a treatment for accidental overdose that is absolutely necessary. For example, in 2017, the Insight Clinic in Vancouver had to administer naloxone to treat overdoses in 58% of heroin users, 55% of cocaine users, and 57% of crystal meth users. These statistics prove that naloxone is a life-saving drug. Among people who accessed harm reduction services in British Columbia in 2019, 69% reported owning a naloxone kit. So these findings demonstrate that people who use stimulants and opioids are taking responsibility for their own safety by using drugs in an observed setting. They are also taking responsibility for the safety of their community by owning a naloxone kit that they can use if they witness an opioid overdose. People that use drugs are aware of the risk associated with drug use, and they are engaged in reducing harms for themselves and their community. So here is a review of my rebuttal against my opponent. So harm reduction programs are safer for residents with a goal to control complications of substance use, and supervised injection sites are important in keeping drug users safe from infection and violence. Harm reduction programs do not contraindicate the Canada Health Act by offering free services and supplies in order to use drugs in the safest way possible. And harm reduction programs do treat individual needs with options for treatment readily available to those seeking help, and treatment with life-saving measures such as naloxone when required. Finally, I will end on a review of my points of why harm reduction programs are medically necessary healthcare services. They provide essential services to keep people healthy, such as safe injection sites. They promote safe and secure complementary therapy, such as free opioid alternative medications. And they relieve the financial and physical burden on the healthcare system by preventing accidental opioid-related overdoses and death. So harm reduction programs do align with the pillars of the Canada Health Act, which are public administration, comprehensiveness, and accessibility. So here is a list of references I used to compile the evidence for this debate. I will link the other two parts of this debate in the description box below once they've been uploaded. You can also find all the links to my presentations on my ePortfolio website, which is linked here. So I just want to thank you so much for listening to this presentation. I look forward to getting your feedback on the first two parts of this debate. Have a great day.